very good nurses because we just don't have the hours to offer right now. We are also implementing a salary freeze for non-represented employees. That means that the majority of our employees are represented by a union contract. We have 2 unions. We have a great relationship with our unions, and we're hoping that our unions will partner with us and work with us to get through this difficult time. For non-represented, the union contract calls for a 3% pay increase starting in July of this year. For non-represented employees, we're not going to be able to grant that 3% pay increase, and we have had one meeting. We'll have another meeting as well to ask our unions to join with us to consider an amendment to our union contract to have a salary freeze for our represented employees as well. And that gets to the next point, which is union negotiations. We're partners in this. We sink or swim together, as I said. I was very encouraged by the meeting we had with both our unions. I think a couple weeks ago, I think they understand the situation. They know that, as we said earlier on this evening, it's not just Bear Valley Community Hospital. It's not just hospitals. It's not just California. Everybody's struggling right now, and I'm really pleased to see that employers and unions all over the country are able to work together to work on plans to help save funds during these difficult times. I did tell our union representatives that I am 100% in favor of, once we turn this around and get this hospital back to being a profitable hospital, to reinstate any increases that were negotiated in the contract. But we are going to ask for the help from our unions at this time. Other expense reductions that we're looking at, we have an employee discount program in place which allows our employees substantial discounts for using services at the hospital. It's a great program. It's a good program. It encourages our employees to use services here rather than leaving and going to a hospital down the mountain or across town. But we're writing off over $100,000 a year on employee discounts, and so we're not proposing to completely eliminate the employee discount program. We're proposing to reduce it by 50% so that our employees still would get a discount for using services in our hospital within our district, but would not be a 100% write-off for us as it is now. We are implementing a hiring freeze effective immediately, an overtime freeze for any overtime that is not absolutely essential. We're putting limits on travel and training. We're reviewing vendor contracts, again, to see if there's contracts that can be renegotiated or eliminated, and we're having weekly meetings with our managers to review expenses. Rudy, I'm going to let you cover the next couple of slides. That we've talked about the revenue enhancement opportunities. We've talked about the expense reduction opportunities. And by the way, we've calculated if we were able to implement every single one of those expense reduction strategies that I talked about a moment ago, that would be a $2.5 million positive impact on the hospital. So in other words, if we were able to do all of those expense reduction strategies and all of those revenue improvement, it would be a $3.5 million positive turnaround for the hospital. There's more we can do outside of those, but that would get us back into the black. The next section, I'm going to have Rudy talk about ways that we're working on to improve our cash. We need to get to the point where we're profitable again, so that we can reverse some of those slides that Rudy had early in his presentation, the bar graph that showed our cash reserves going down, 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 down. There's 2 things that we need to do in order to build those cash reserves back up. Number 1 is we need to be profitable. When we're profitable, we're able to put money back into cash reserves. The other is we feel that we need to refinance the Brenda Boss Family Resource Center. There are opportunities for us to do that, which also will put cash back into reserves and get us back into a healthier cash position. So Rudy?
One of the items we're looking at to improve our cash is to go through into finance the Brenda Boss Resource Center. The question is, why do you want to refinance it now? If you recall, during the first part of the presentation, talked about establishing the rural health clinic per visit amount that we get reimbursed, we get paid. You established the reimbursement for that rate during your base year. Base year is defined as July 1st through June 30th. So we have a situation here that during our base year of operations, we want to have more costs. Right now, we get no benefit from it. So as we go through into our base year of operations, we'll go through and we'll increase our expenses by depreciation, interest, and other operating costs. Hopefully, we'll go above the $250 per visit that we get from our current rate from the state of California. That'll help us out quite substantially. Moving the patients from the OB patients from our Bear City operation over to Bear Lake increases it by about $50 per visit. So that also increases our revenue per day. We have a situation where with our cash conversion cycle. As we talked about that, we have an item where we're looking at e-payables. E-payables is a really interesting concept because we could go through and squeak up another 5 to 7 days in our accounts payable. We talked about in the cash conversion cycle, if you take your AP, your AR, accounts receivable days, your inventory days, minus your AP days, we can move up our cash conversion cycle or reduce it by about 5 to 7 days just by putting in e-payables. This is a process where what happens is you negotiate with your vendors to go through and accept the payment terms. And then what happens is the vendor, rather than having a check, is now going to be receiving a credit card. It's just like going to Best Buy when you get a rebate to give you a credit card. Same basic process. But that'll go through and help us out a couple ways. Number one, it'll push up our AP days, which we want to get up to 32. Ideally, like to get up to 36. So you're going to go from 36 days in AP, ideally, versus 46 on our collection. We'll drop that down to 10 days. Remember, in 2005, 2004, we were at 40 days. We could be as much as 30 days quicker in collecting our cash, which pushes up our reserves. And it's very important to go through and manage it that way. We have a situation where we're looking at metrics for management processes for improving efficiencies in the hospital. That'll also go through and improve our cash and our bottom line. It's an everyday process where you go through and you contact your patients, your insurance companies to speed it up. And as you go through in this whole process, we have to look at everything. Like I said, what Ray said, I'm very serious about it. Everything's on the table. That includes me too. And it's a situation where we just have to go through and make sure we look at it and we do it responsibly.
We also want to welcome Liz Harris, who's here representing Supervisor Ramos. Thank you for being here tonight, Liz. Do we have any questions? We've got one more final segment to go through after we take questions here, which is, leading up to our big finish where we're going to talk about reinventing and transforming Bear Valley Community Hospital. Yes?
I was under the impression when they discussed the Brenda Boss Center, before it was actually started, that it was going to be financed through a low interest rate loan and somewhere between 1.5% to 3%, so it hasn't been financed all this time?
The question was, if everybody in here, was the Brenda Boss Family Resource Center financed with a low interest loan? And the answer is no. Part of the reason why the cash reserves for the district have declined over the last several years is there's two factors affecting our cash reserves. One is that we've been funding the Brenda Boss Family Resource Center through cash reserves, and the other is we've been losing money. The combination of losing money and funding that building have cut our cash reserves in half in just a year. So no, the opportunity that is before us now is to go ahead and finance that building and build our cash back up. No, that did not occur due to the fact that financing wasn't very attractive and the hospital had significant reserves at the time to build the building. Yes?
Just as part of the planning, it's something I didn't understand, and I was educated by reading it. Took a couple times. When they finance the building, it's calendar year. So if it doesn't open July 1st, then that first 11 months of the year that it's open, when you have the greatest amount of money expended to fix the glitches in the system, that's when you spend the most money. But the pay per visit rate, hypothetically during 14 into 15, would not be determined until 2015 into 16. Did I express that right? So it's real important when we open, and it's real important that we try to get the costs, the money that we're spending. So when Reddy said that, I said, would you be better off to stretch your loan, not taking the loan for another 11 months to get to 2015? And it might be. I think that's a business decision that administration needs to make. I didn't understand that. That rate per visit is a big number.
Mm-hmm.
Yeah, I mean, it's a permanent number. That's why they get $250 at the
Yep.
FHC. So that targeting that date is really paramount in what they do and when the construction gets finished.
Yes, the rural health clinic and the family health center work similar to the critical access hospital program. It's cost-based reimbursement. So to the extent that we have higher costs, that gives us a higher Medi-Cal rate as well. So by financing the building at this point in time, we're actually increasing our costs at the right time, which will allow us to get the best Medi-Cal rate for the rural health clinic.
If you open July 1st.
Rudy?
Actually, with cost reimbursement for rural health clinics, it's better than cost reimbursement.
Actually, it's better to have cost reimbursement for rural health clinics, because what happens with a critical access hospital, your rates are, each year it changes, so your reimbursement will change. But with a rural health clinic, your rate is established, it's permanent, and you get, each year you get your adjustments based on, let's make pills. That's otherwise we won't take them. You get your rate adjusted by a COLA, but if your costs go down, your rates stay the same. But with your costs go down in a rural hospital, a rural hospital is a critical access, your costs go down, so does your reimbursement. So it's actually better.
Ray, Helen has a question.
Yes, Helen?
With the higher reimbursements coming in for patient care in the rural health clinic in the Brenda Boss facility, and if you get the financing to replenish the reserves that you have used up, I'd like to know how much you still have left in reserves. And I ask that because I think that it is critical to know what the payback is, how long it's going to take the Brenda Boss facility to pay for that facility, number one. What are the reserves that we have left? I mean, if you do get financing, you're going to have to pay that back. But all of this makes it so important that this parcel tax gets passed by the community.
Yes, and that's an excellent point, Helen.
Right now, we have $7 million in reserves.
And what's the payback period?
We have it's about $4 million building. The payback, I want to say 8 years, but that's what it comes down to be. So it's not that bad. It's a really good turnaround, and it could be quicker depending upon how that volume turns out in the clinic. With the pediatric nurse practitioner, I think that's a really good number. With the telemedicine, I mean, it's Skype on steroids. That has something to really go. I mean, I've experienced that in my own medical process with my cardiologist. He put a Bluetooth on and he was off in his office. It's just amazing what can be done with it. So as we get involved in this, I think it rolls out. It could even be better.
Yes,
an additional
Helen.
comment. And that is that I think it is absolutely critical that we put telemedicine in place because it improves the overall health of the healthcare district. But having said that, I know that telemedicine is not inexpensive. So all of these things we're talking about are going to be a cost to the healthcare district. So if it is 8 years for payback, then it's even more crucial that the parcel tax gets passed by this community. Or we're going to end up, I think, in the same position we're in now.
Your point well taken, Helen. You're exactly right. And one of the things that Renee has recently told me several times, she's done a lot of research on telemedicine, talked to a lot of hospitals and clinics around the country, and the majority of them say that telemedicine saved their hospital too. The combination of telemedicine and critical access hospital designation, we're doing all the right things. We're doing the things that a small hospital needs to do in order to survive. But you're right. What you're saying is we can't wait 8 years. We need to pass the parcel tax next year so that we'll be here in 8 years. You're exactly right. Yes?
What's telemedicine costing us? Are we leasing it? Are we buying it?
The proposal is to lease. We're looking at 2 units that one would be placed in the Family Health Center in the Brenda Boss Family Resource Center. One would be placed in the hospital. The monthly lease payments for the 2 machines is $3,000 per month. And there are additional costs for contracting with physician providers from outside the community, the psychiatrist, the cardiologist, the neurologist that we talked about. But the figures that I gave you a little while ago, $174,000 improved revenue in the Family Health Center, $370,000 improvement in the hospital, is after expenses for the lease payments and for the specialists. That's calculated to be pure profit if we're able to use the service to the extent that we think that we can.
If I could just speak on that as well, just because I have done some research on it as well. If you think about it to some perspective, if we rent a telemedicine unit for $3,000 a month, it's less than 25 visits a month to repay our rent on it. And we are projecting many more than 25 visits a month based on the fact that we see approximately 70 patients a month for pain management. Half of those patients should be in some kind of behavioral health or some kind of psychological assistance provision through care as well. There's 35 right there off the top, and that's without us even locating. And right now in Big Bear, we are, as far as health provider shortage area for psychiatric and mental health services, a federal qualification for a health provider shortage area, which means that we would be able to either attract a psychiatrist here or through telemedicine for free, meaning that they would have to repay their loan payments by working here in this community that's underserved. Federal qualifications is 14. We're at a 16. We are 2 above the level that is required for federal qualification. There's so many avenues for us to be able to expand services on an outpatient care service basis, and I so appreciate that you're telling the story as well, Helen, because the fact is as well is that the clinics pay for themselves. The services that we provide right now, because of the revenue that we generate, the revenue that mom and dads brings to us as well, even from a one-stop shop concept. Think about a person coming into mom and dad's project that's never been to us before, or that doesn't want to take their child down the hill because they can't afford to get in the car and take their child down the hill, to walk next door in the same building to take your child to be seen for pediatric services, or a family practice physician, or a nurse practitioner is right there in the same facility. So as I said, we're paying for ourselves. We can pay that 8 years if that's how long it's going to take. And prospectively, it's not going to take 8 years. We're talking about programs like CPSP, which is Comprehensive Perinatal Services Program, where traditional OB is what we used to provide here in Big Bear, but now through the implementation of CPSP, which is one of the only programs that has not been cut by the state government, we can go from providing 10 traditional OB visits to 50 visits utilizing this program, which enhances nutrition, psychosocial, health education in group settings that Mom and Dad Project can help us with, that physical therapy can provide as well for postnatal exercise or prenatal exercise. The possibilities in an outpatient clinical services area as a resource center are endless. And we are so appreciative that you're here to support us, that Helen is here to point out we need this parcel tax because we are supplying services to people who live here in the valley. And all we want to do is make those services better for everyone who lives here.
Thank you, Renee. And yes, Rudy just reminded me of one other positive aspect. We received a $30,000 grant from the California Endowment last year specifically to go to telemedicine. So at the rate of $3,000 per month for the lease of equipment or $36,000 per year, the first year lease payments was already paid for by the grant. Are there other questions before we get into the last segment? And we're going to try and get you out early. We have the room reserved till 9 o'clock, but I'm sure that if we can get you out early, you wouldn't mind that. And now we're getting into the part of the presentation that I'm most excited about. That is where we talk about the opportunity that lies before us to convert Bear Valley Community Hospital into a critical access hospital. I'm very familiar with the critical access hospital model, having been, I think, the only hospital CEO in the state of California to open 2 critical access hospitals. The critical access hospital program, as you will see from the presentation, is a new model of hospital specifically designed for small communities. But in my view and my experience, it's a perfect model for Bear Valley Community Hospital. It's a model in which the federal government has designed a small hospital that has a 24-hour emergency department that's available to serve the local community. It's incentivized by improved payments under the Medicare program, and quite frankly, as I said in the presentation, there are thousands of critical access hospitals in the United States today, and virtually every single one of them will tell you that had it not been for their decision to convert their hospital to critical access hospital designation, they would be closed today. I think that applies for our hospital as well. This is perhaps the most important part of the presentation that we covered this evening. Okay, so the bottom line. Here's the bottom line. Without any changes to the Bear Valley Community Healthcare District operations, the district will lose $3 million from operations this year. Revenue enhancements and expense reductions are needed, but the long-term survival of our healthcare district depends upon the district reinventing itself and making itself a model small rural healthcare facility, which we don't currently have in place. The first aspect of the reinventing ourselves is to become a critical access hospital program. Dr. Fagan stole my thunder earlier in the presentation, so I've already told you what a critical access hospital is. And the opportunity is in front of us. It's been a life-saving program for hospitals across the country. It's something that we can do, and I believe we can do it this year, 2013, before the end of this calendar year, and we need to do it. We need to grow our outpatient revenues. We've talked about the Family Resource Center, but we've also talked about the other wonderful outpatient services that we have in the district, our diagnostic imaging department, our physical therapy and rehab department, laboratory, the outpatient surgery services that we have. The future of healthcare and hospitals, as was pointed out earlier on, is not in inpatient care, it's in making money off of outpatient. That's the direction that we need to go. And in order to support that, and to support to some extent some of the earlier information we provided, this is what our inpatient utilization looks like. And you can see that for the last 4 years in a row, our inpatient utilization of hospital beds has been declining every single year. And that's because of the observation bed phenomenon that we talked about a little while ago. Observation beds are converting inpatient services into outpatient services at a lesser rate. This is our skilled nursing facility, which has been fairly stable. a little bit of a dip in the last couple of years, but we stay pretty full occupancy. We have, as we've talked about, an excellent skilled nursing facility. There is an opportunity here, by the way, and Barbara mentioned it in her first comments. I caught it. Maybe nobody else did. Another one of the advantages of having spent as many years as I have in rural healthcare is I know about swing beds. And there is an opportunity to convert those skilled nursing facility beds to swing beds at a higher reimbursement rate, which will also help us with our critical access hospital designation. Fear not. Skilled nursing facilities and swing beds are essentially the same thing. The advantage of swing beds over skilled nursing facility beds are they can be used as either acute beds or long-term care beds. That's why they're called swing. Swing to acute, swing to long-term care. They're acute beds. They receive the same level of reimbursement, maybe a better reimbursement as skilled nursing facility. And there is an opportunity for us, and luckily for us, we're fortunate in that Bear Valley Community Hospital used to be a 30-bed acute hospital, which means that all 30 beds at one time met acute licensing requirements. In order to convert those beds to swing, they need to be brought back up to acute licensing standards. I haven't done all of my homework yet, but I have spoken to the state, and it looks like there's an opportunity for us to convert those back to acute to swing, which would allow us to get better utilization of our beds, improve our reimbursement. According to our cost report preparer, that could add $1 million a year to our bottom line as well. So that's big for us. Emergency department is kind of up and down, a little bit down this year, but I expect emergency department to stay fairly stable. That's probably one of the most important services that we offer. It's an outpatient service as well. And then this is our rural health clinic visits we've talked about already. Our rural health clinic is growing, and you can see the last 3 years have been a dramatic increase in, when I say rural health clinic, I'm also talking about family health center. That's a bad habit for me. The family health center is a rural health clinic. So it's always seemed kind of odd to me that we have a rural health clinic that's called rural health clinic and a rural health clinic that's called family health center. They're both rural health clinics, and they probably could have better names, and I've talked to Renee about that as well. But our family health center is a growing business for us. It's going to grow more with the telemedicine service. It's going to grow more with the Brenda Family Resource Center, and those numbers are going to continue to grow. And that's a key part of our strategy for the future. And this is all of our other outpatient, and isn't this dramatic? Since 2002 to 2013, all of our other outpatient services have more than doubled, from 40,000 visits per year to over almost 80,000 visits a year. Doubled. That's where the money is. We talked briefly about affiliation strategy. If you remember in Bruce Garlinghouse's presentation, the very last slide he did was a continuum of affiliation and connectivity type strategies that went all the way from sole independent provider hospital on the far left to essentially wholly owned hospital of a system on the far right, with all of the grades in between of steps moving from sole independent status to fully part of a system, like a St. Joseph's healthcare system, let's say hospital, or an HCA hospital. We need to be moving down that continuum. We need to be affiliating with a larger partner hospital or system. Again, I think that this community needs to embrace the opportunity to be part of a larger system and not be afraid of it. I'm not talking about selling our hospital to St. Joseph's or to HCA or at Loma Linda or St. Mary's, any large hospital that you can think of. But there are opportunities to work in partnership with those hospitals, similar to what Bruce showed on his continuum. There's several steps in between, clinical integration being one of them. In a clinical integration model, you work with a large partner hospital that brings doctors and medical staff. They help to recruit doctors and medical staff to support the small hospital as well as the large hospital. What's in it for the large hospital, of course, is to capture lives, capture the population of this area into the larger system facility. We need to do that. There's many examples. Rudy talked about it a moment ago when he said, all options are on the table, I'm on the table. What he meant about that, he and I talked earlier today, if we could see ourselves being part of a larger system hospital that maybe has chief financial officer services available through the large partner hospital. Maybe we don't have to have a CFO in the local facility. Rudy understands that, and we've talked about it. And maybe you don't need to have a full HR department. Maybe the HR department is through the large partner hospital, or information technology, or other management services. Maybe my position. There is an opportunity to align ourselves with a larger hospital, and that needs to be part of the strategy for the future. I know of small district hospitals just like us in Northern California that have gone through a process of vetting potential partners, and that's a process that I think we need to go through here as well. Again, not talking about selling ourselves. We can still maintain sole independent hospital status, but also take advantage of the bigger buying power and the corporate resources of a larger facility. And that's something I've talked to Bruce about as well. It's not inconsistent with what he's talked about. An example of that, medical staff growth, recruiting physicians. Dr. Bakari, our cardiologist, is an example of a physician that's been brought to our community through an affiliation strategy with Riverside Community Hospital, an HCA hospital. That is an example where they're helping to support a cardiologist to come to our facility. We can do more of that through an affiliation strategy. As Dr. Fagan was talking about with the new reimbursement system, value-based purchasing, thank you. Value-based purchasing, where we get paid on the basis of quality, we need to emphasize providing high quality of care. Some of the things that we're looking at doing in that area are accreditation for our facility, quality measurements, customer service, because hospitals are also being paid nowadays on the basis of customer satisfaction. We talked about it actually earlier today in our medical staff committee meeting. We looked at the measurements that we have for customer satisfaction, and they're good. Our customer satisfaction scores are very good. We compare well to other hospitals in the country. Small hospitals tend to have higher customer satisfaction. The reason for that is smaller hospitals tend to provide more personalized care provided by people that you know, friends, relatives, members of the community. It's less impersonal than a large tertiary hospital. And patient advocacy program is part of our quality of care initiative as well. We're implementing an electronic medical record system. The board of directors approved the purchase of an electronic medical record system in November of 2012. In January of 2013, we signed a contract with CPSI. As we talked about earlier, and Dr. Fagan prompted me on that one too, is being paid for by the federal government. I told you I'd get to it.
I know, I wasn't trying to rush you, but just a lot of cash.
I'm with you. I'm staying up with you. And then we need to be cost effective and efficient and productive. So we do need to be very efficient and maintain productivity and as I said, staff our facility appropriate for the level and quantity of services that we provide. We also can take advantage of group purchasing, as Rudy talked about in his presentation, collaboration among providers and more efficiency and productivity. In summary, almost done. Bear Valley Community Healthcare District in the future will be a critical access hospital with emphasis on outpatient services, and affiliation agreements could be more than one, high quality and efficient and productive operations. So what can all of us in the room do? First of all, thank you for being here tonight. You did the first thing, which is to be here. And I can't thank you enough for being here tonight to hear about our hospital, to hear about the challenges that we're facing. Obviously, you're very concerned. Obviously, you care about this hospital. I appreciate that very much. You wouldn't be here if you didn't care about this hospital. And so what you can do is to support Bear Valley Community District Hospital. You can support it by using it. I encourage your doctor if you need a lab or x-ray test or need to see an excellent family a pediatric nurse practitioner. You can help us by using our local facilities. You can help us by spreading the word that this really is an excellent hospital, and this community is very fortunate to have this hospital. It's fortunate to have a hospital of this quality and caliber of service. And as Helen reminded us a little while ago, you can help support us by voting for the parcel tax when it comes up for election. And now I'm ready. I'll take the question way in the back. Maybe you're going to kick us out. I don't know.
No. What happens if the parcel tax does not pass?
The question was, what happens if the parcel tax doesn't pass? That's something I try not to think about. If the parcel tax doesn't pass, I don't see a future for this hospital. We would be, at that point in time, we would have to cut services to the level, I think it's impossible to cut services to the level that we could maintain quality and also keep this hospital going. So I'm going to say that if the parcel tax doesn't pass, this hospital doesn't have a future.
Yes, Mr. Hino,
Just
if I
add
could-
one quick thing on the parcel tax that Helen brought up. I went home and looked at my own today, my own property tax bill. I went and looked at my own property tax bill, and for instance, Barwa is $419 for myself, my home. For the refuse, it's about $380-something. For the San Bernardino Community College, it's $134. For our own school, it's $107 or $8, and at the very bottom is a $45.30 for the hospital. So I called the county to ask what the 30 cents was, because as far as I knew, it was $45. And the 30 cents is for them to just do their processing. They added that 30 cents for each parcel for those. Is that not just $50? And then one other thing, housekeeping I wanted to say. First of all, I miss Julie Grandy. My husband John did remarkably wonderful fundraising for this hospital, and I'm sorry I missed you earlier. And Connie Swank from the Hospital Foundation, and Liz Harris, the Senior Field Supervisor, Mountain Rep from Supervisor Ramos' office, and the President, Rich Collier here from Rotary. I missed quite a few of them. I'm really sorry, I apologize. The other thing I wanted to say before Ray picks up again was, please don't forget to come over here to this table. There's a lot of literature for you over here that the staff has put together, so please come and pick this up. And I'm putting Ray's cards there so you can all call him.
I see we have a question in the back.
Yes, Ray, I just wanted to bring to light another service that's been offered since 2008. It's chiropractic care through the Rural Health Clinic. I'm Dr. Calvin Freeman and provider for that, and that's available for Medicare patients and is a very valuable service as our population ages and a revenue source for us. Thank you.
Thank you. Thank you for being here, and thank you for providing services to our patients. Yes?
I'm probably the oldest representative here. After I took my years, not that, the board is. I can tell you that I think everything here has been pretty transparent. I work in Texas now, and I see what's happening in the rest of the world. And they've really given you an adequate representation of what's going on. I don't think there's any hidden things. I think you really have the real straight poop. And I don't know how to address it any more than that, because I see it in Texas with the sequester, and the emergency room is not the place I left 5 years ago or whenever it was. We have more indigency, we have more bad debt, we have a harder time getting people to be taken care of, whether they're insured or not. I mean, this is a changing thing, and I believe in his 3-month tenure here, this district has to be fluid. If we're not fluid, it will close. I believe that. And I think that's something that we all have to be willing to address in whatever changes are made and all the stuff they're talking about. But I think they've been honest.
Thank you, Dr. Fagan.
And I have made Ray red on occasion.
He keeps me on my toes for sure. Bruce, anything that, other questions?
I guess I would like to say, as an outsider, I am just, I'm just very impressed. Again, we travel around, we talk to a lot of communities, but congratulations. You know, give yourself a hand. Absolutely. So, thank you.
Thank you for being here all the way from
Really good,
Denver.
buddy.
Connie?
I wanted to, I don't know her very well, just met her at meetings, and Sara, I want to congratulate you on this idea. It is extremely important for our members of our community to understand what they're going to be voting on. And they're questioning new buildings, and they don't understand where the funding is coming from. And if you're upfront and you tell the truth, you have nothing to hide. And I watched this board of directors who could pay nothing, and they work day and night to keep this hospital here. And it's just been a pleasure attending your meetings and seeing the progress that you're making so quickly and working towards maintaining this hospital. You really have got to be correct.
Thank you for coming.
Yes, Joe.
My name is Jo Merrill. I am the telemedicine coordinator for the Family Health Center. Just a couple of things to clear the air. Oh, sorry, I'm short. First of all, I'm currently working on applying for 2 different grants for the telemedicine program. It hasn't even begun yet, and we're already hoping to get these grants to increase the service and expand the program and pay for more education for myself and the presenters and all the rest of the staff involved in the program. So that will further offset the cost. Also, the majority of my training has been done online, which is either free or I've gotten many, well, 2 or 3 anyway, of the classes that I've had have been paid for via scholarship based on our HPSA score. So just letting you know, cost effective. One of the ones that I'm applying for is $10,000 and the other one is $5,000. So hopefully we'll hear about those by the end of the year.
Helen has a question.
No, I have a comment. And that is, I was trying to tag on to the end of what Connie said about how wonderful job the board has done. And I also want to say what a wonderful job I think you have done in the short time you have been here. And I hope that the next time I see you at one of these functions, you don't have interim behind your name. That's my
I just want to comment that I hear a lot, and I know Judy Bowers hears a lot too, from the public, and they have questions, and they have comments, and they have rumors. Would you believe that in this community? Anyway, I suggest that you get to know the board members, come to their general meetings. If you have a question or concern, come and find out. Don't spread the rumor.
Thank you, E.T.
There's a lot of opportunities for saving money. You have the new building you guys are looking at building through the electric company. There's not a whole lot of renewable resource opportunities up here in Big Bear. But one that you do get for new construction is you can do solar. You can do different options that actually have a reimbursement through Bear Valley Electric as well as through state funding. There are also different programs I don't know if you guys have all looked into in regards to California was doing a pretty much they fork over the first X amount and you have to fork over the equal amount. Solar is another way to obviously reduce your monthly cost, through your electric company, because obviously they're buying it from Southern California as in other areas, as well as generation. I don't know if anybody in here works for Barwa at all, but I used to work for the electric company, and one of the things that Barwa does, as well as Snow Summit, Paramount, they generate power, especially during peak times, to help offset the cost. There are other opportunities in generating potentially your own power, using the heat to heat the building as well as cool the building, which now gets rid of your heating and cooling costs. I mean, there's so many opportunities just on the electricity side. I don't know if you guys have looked into that. That's one question. But the other is, what about technology? And what do you guys, besides the medical record system, what else are you guys doing? Because technology can reduce your costs, like for instance, online training.
Yes, thank you for that. I'm going to have Rudy talk about what we're looking at in terms of energy efficiency in the new building, and you're exactly right. There's lots of grants and money available for energy efficiency, which does save cost for the facility. I will say, as far as new technology is concerned, one of the things that we're looking at in the next year is to replace the CT scanner for the hospital, but there are other technology things that we're looking at as well. Here, Rudy.
To address the issue relative to the utilities, we're part of our improvement plan is going out and talking to a firm, Utilitech, to review all of our utility bills as well as our telecom bills to crush the cost down. In addition to that, last year we went through and we refitted our boilers at a cost of $326,000. That also improved it. So we're looking at everything. When I said all options are on the table, I mean all. So that's just go right back to what you talked about.
I realize you've got a lot on your plate right now, and if not a gorilla in the room, maybe a chimpanzee. We've never retrofitted for earthquake. Where do we stand in complying with the mandate?
I can answer that. Pretty close. Basically, and this is to the best of an old man's recollection, we were told that we had to retrofit by 2017 or 18. Then there was another edict down from the state that took it to 2029 or 2030. The hospital, from what limited I know about construction, the one wall that runs by the CT scanner and retrofitting is probably not something you want to entertain in a building that's over 30 years old because of the value and everything else. The one thing he did mention that is something that is going to come up in probably the next 18 months, maybe in this year's budget, is the scanner. Just let me tell you what happens with that, and this is Scott telling me numbers. A new scanner costs $500,000. You order the scanner, don't pay for it, and you have to apply for OSHPD, which is the structural wall right there running down the hall. And what happens is you take 18 months to get through OSHPD to get a scanner that's now 1.5 years old. And we went through that once. We have a 4-slice scanner versus like state-of-the-art 16. And that's part of it. I really think that if you get to the point when Obamacare and whether Hillary's president and whatever happens in the future, I think the financial viability of this hospital and small hospital is going to be determined, and then I think you're going to have to make a decision about building a bigger hospital and a new one. I'm just saying that's because I used to fight Vi all the time because she wanted to spend a lot of money, and it was never in concrete that we had to do it in writing, and I think that's kind of where I got on sideways with her.
I appreciate the question. I'll try to add to it. I'll admit I'm not totally up to date with what the seismic situation is at our hospital, but I can tell you what's happening around the state of California. And for everybody's information in the room, probably most of you are aware of what that question has to do with. Several years ago, over 10 years ago, there was a bill passed in California called SB 1953, which required that all hospitals in California be brought up to current seismic building codes, and there were specific deadline dates that were included in that legislation. There was a deadline date in 2006, I believe, and 2010. That's turned out to be a moving target because there wasn't enough money or enough time to rebuild all the hospitals in the state of California. So one of the things that happened was there was new regulations that were passed, and new construction criteria that was permitted for hospitals, which allowed hospitals to qualify for the later implementation dates for construction by passing. The one that I'm familiar with was called the HASIS scoring criteria. There's several hospitals, including the last one that I was at up in Northern California, was able to pass through the HASIS scoring criteria and extend our deadline date from like 2016 to 2030. So that's probably what happened here.
That's exactly what happened.
Yeah. And the other thing, just because I've lived there for 15 years, that hospital's old. And I think this community needs to realize that. I mean, some of the plumbing and the planning with Barbara, and I was never on planning. I've been there for 3 months. I've enjoyed every minute of it with them. But the reality is, those pipes upstairs, it's worse than my kid's bedroom. I mean, and they're changing drains and fittings and couplings now as maintenance tries to do it. I mean, if the world settles down, the district needs a new hospital.
Any other questions? Thank you so much, everybody, for coming tonight.
I realize that for many of you that are watching tonight that you've been longtime residents of the community and you've heard the hospital come to you before asking for your support in the way of tax dollars. I'm encouraging you this time to please watch this message carefully. Repeat sections that are of particular importance to you if it's helpful. This is a critical time in the lifespan of the Big Bear Lake community as well as our Bear Valley Community Hospital. We are facing an unprecedented time in our country today with national healthcare reform, Obamacare as many call it. It's changing the way that healthcare is delivered in small communities and large communities throughout this country. Now more than ever, hospitals need to be able to work together, as we talked about this evening, and need to be able to rely upon resources available in the community. I'm going to take this opportunity to extend an invitation to all of you to please let us know here at the Bear Valley Community Hospital, and me particular, if you have questions about anything that you've seen this evening, anything that you've heard in the community, whether it be as a part of this presentation or questions that have come up around the dinner table. I want to be here to help you and help our community understand the pressing needs that are facing our hospital and our community today. I am very willing to come to any organization at any time. I am very available to speak to service organizations like the Rotary Club or the Kiwanis Club or the Seroptimus Club or any church organizations. I'm happy to come and speak to church groups or any local community groups, CSD groups. I am very willing to come to any group and speak at any time. It doesn't matter, day or night, day or the week, anytime. If you invite me, I will come. I will show up any place, anytime. So please take advantage of this opportunity to receive a personal message from our local hospital on how you can help and the importance of your help in order to protect healthcare in our community for decades to come.